All right, everyone, let's jump right in. Welcome to your quick clinical update on managing COPD. We're going to cut through the noise and focus on the latest in drug therapy and, most importantly, the key counseling points you can use every single day to really help your patients. And I want to start with this quote because it just perfectly captures the core challenge of COPD. This isn't just about the lungs, right? It's this vicious cycle. A patient feels breathless, so they move less. Moving less makes them weaker, and that weakness, that deconditioning, just makes the breathlessness even worse. Our role as pharmacists is to jump in and help break that spiral. So just to get us all on the same page, here's the official definition. Now, for us, the most important words on this slide are preventable and treatable. Yeah, it's progressive, but what we do matters. We're not just handing over an inhaler for daily symptoms. We are actively trying to stop those exacerbations, because that's what really drives this disease forward.
So here's our game plan. We'll touch on the foundations, then dive into picking the right inhaler, what to do when you need to add more therapies, how to handle those scary flare-ups, and we'll wrap it all up with the most important counseling points to remember.
Okay, first up, the foundations. And that subtitle says it all, doesn't it? Beyond the prescription pad. Before we even think about a specific drug, we have to make sure these fundamental pieces are in place. Look, the medications we dispense just plain work better when these things are happening. Smoking cessation, that's the only thing that actually slows the disease down and reduces mortality. It's number one. Then you've got pulmonary rehab and physical activity to fight that downward spiral we talked about. And a written action plan, it's been proven to cut down on exacerbations when we pair it with good education. And just a quick note for context, the official diagnosis comes from spirometry. They're looking for that FEV1 to FVC ratio to be low, even after using a bronchodilator. This is the test that gets the ball rolling on therapy.
Okay, now let's get into our world, choosing the right inhaler. We're going to walk through the modern, step-by-step approach that really focuses on maximizing how open we can get those airways.
So, the very first decision point is rescue versus maintenance. It's pretty straightforward. On the left, you've got your short-acting inhalers, the rescue guys. They work fast for immediate, as-needed relief. On the right, you've got the long-acting ones, the maintenance crew. These are the foundation, taken every day on a schedule to prevent symptoms from showing up in the first place. Okay, so if we're starting with just one maintenance inhaler, which one do we pick? A LAMA or a LABA? Well, while both of them are great for improving lung function and helping with shortness of breath, there's a key difference. The clinical pearl here is that LAMAs are flat out better than LABAs at preventing exacerbations. And that's a huge deal. Now, this is a major shift in practice from years ago. When a patient needs to step up from a single inhaler, where do we go next? The evidence from huge trials like the FLAME study is crystal clear. The next best step is combining a LAMA and a LABA. This dual bronchodilator approach is better at preventing exacerbations than jumping to a steroid-containing inhaler, and you get to avoid all the side effects of the steroid. All right, let's talk counseling. For LAMAs, you're going to want to warn patients about classic anticholinergic effects. Dry mouth is the big one, maybe a metallic taste, and just mention the small chance of urinary retention. For LABAs, think beta-agonist effects, feeling a little shaky, nervous, or like your heart is racing. And of course, if they're on a combo, you've got to counsel on both. So what happens when a patient is already on that gold standard LAMA-LABA combo, but they're still having flare-ups? Well, that's when we need to start thinking about adding some more advanced therapies into the mix. And this really is the million-dollar question in COPD management today, isn't it? We know we don't start with an inhaled steroid anymore, but when is it actually the right move to add one and create that triple therapy? The answer, it turns out, is in the blood work. And here's the answer. It's all about the numbers. We look at their peripheral blood eosinophil count. If that count is at 300 or higher, that's our magic number. Those are the patients who are most likely to actually benefit from adding an inhaled corticosteroid to their regimen. It's a simple, data-driven decision. Now, anytime you dispense an ICS for a COPD patient, this is a critical counseling point. You have to tell them it increases their risk of pneumonia. It's a well-known risk. And, as a little clinical pearl, some data suggests that risk might be a bit higher with fluticasone compared to budesonide.
And beyond pneumonia, there are a couple of other things. You've got the local side effects, like thrush or a hoarse voice. The fix for that is super simple and effective. Tell every single patient to rinse their mouth with water and spit it out after every single use. You should also be aware of some of the systemic risks, like bruising or effects on bone density, that are worth keeping an eye on long term.
There's one other advanced therapy to know. and that's roflumilast. It's an oral pill, and it's really for a niche group of patients. Someone with severe COPD who also has chronic bronchitis and is still having exacerbations on everything else. The counseling here is vital. Watch out for GI issues and weight loss, but pay really close attention to any mood changes like new anxiety or depression.
Okay, let's switch gears from long-term maintenance to what to do in the moment, managing an acute exacerbation. This is where a little timely advice from you can literally keep a patient out of the hospital.
So the first question during a flare-up is always, do I need an antibiotic? And we can help guide patients with the 3 cardinal symptoms. 1, is your breathing worse than normal? 2, are you coughing up more stuff? And 3, the big one, has the color and thickness of what you're coughing up changed? The rule of thumb is, if you have at least 2 of these symptoms, or if that third one, the purulence, is present, then an antibiotic is probably needed.
And for your typical patient at home who isn't super high risk, our first-line antibiotic choices are pretty simple. We're talking amoxicillin, doxycycline, or Bactrim. And the key here is that a short course, just 5 to 7 days, is usually all it takes.
Now, for the oral steroids, this is a huge practice-changing point. The evidence is now very strong that a simple 5-day course of prednisone around 30 to 40 milligrams a day is enough. And here's the kicker you can share. For a short course like this, they do not need to taper. This busts that old myth and makes life so much simpler for our patients.
Okay, let's bring it all home. Let's talk about the absolute highest impact things you can do at the counter. This is where we put it all together to really make sure our patients get the best possible outcomes.
Honestly, if you forget everything else, please remember these 2 things. Number 1, inhaler technique. The best drug on the planet does nothing if it just hits the back of the throat. Show them how to use every new device, and then check their technique again every time they visit. It is the number 1 reason for treatment failure. And number 2, vaccinations. Make sure every single COPD patient gets their annual flu shot and is up to date on their pneumococcal vaccines. This saves lives. It's that simple.
So I'll leave you with this thought to take with you. Based on everything we just talked about, what is the one thing? Maybe it's checking their inhaler technique. Maybe it's busting that steroid taper myth. What's the one thing you're going to make sure to reinforce with the very next COPD patient you see? Thanks so much for your time.